This presentation is over acute otitis media, and these are the clinical practice guidelines by Elizabeth Mustachia. So just to introduce you to this topic, acute otitis media is the most common reason for the prescription of antibiotics for children in the United States. Acute otitis media can occur at any age, but is most common in children under 10 years of age, and we'll talk about why that is here in just a few minutes. In approximately 80% of cases, these infections will resolve without treatment. However, treatment is often necessary because these types of infections are so common. The goal of treatment is to clear the middle ear of infection with the use of antibiotics, which we'll talk about different types of antibiotics that can be used for this here in a few moments. Many risk factors may be present, and because this is primarily a childhood illness, parents must be educated on how to prevent it. Because acute otitis media is such a common condition, antibiotic resistance has become common, and again, another reason why prevention is so important. The clinical guidelines involve providing the appropriate treatment for the individual's clinical presentation and the appropriate education for the parents and patients. Education should involve learning how acute otitis media occurs, how acute otitis media is managed with medications, the importance of and how to successfully complete the medication regimen, because we as nurses know this is very important to help prevent resistance. Potential side effects from some of the medications that may be prescribed, and learning the best ways to prevent acute otitis media. So the reason why children get acute otitis media so frequently is that their eustachian tubes tend to be a little bit smaller and more horizontal. The reason why it occurs is the eustachian tube, for some reason, the flow of the fluid from the middle ear to the pharynx is not draining very well. And so there's a reflux of fluid and bacteria back into the middle ear. So again, because of the size and shape of their eustachian tubes, younger children tend to have more of a problem with this. And sometimes they'll have a problem with it and not necessarily having an infection. They'll have what's called a middle ear effusion. There are multiple other risk factors that can cause this buildup and infection of fluid in the ears, and those can be allergies, being around people that are ill, because that causes the child to become ill, and that can create more fluid in that middle ear. Secondhand smoke causes irritation, and some types of dietary issues can cause fluid buildup. You know, if the child has a sensitivity to, say, gluten, or some children will have milk allergies and things like that. There are a few bacteria that are the most common causes of these middle ear infections. One is Streptococcus pneumoniae, and there's a vaccine for that, which we'll talk about here in a little bit. The other one is Haemophilus influenzae, which is actually not the flu virus. It is a bacteria that a scientist at one point in time thought was what caused the flu, so that's why it has that name. And then there's Moraxella catarrhalis, and these are the most common types. So diagnosis can be made when there's a moderate to severe bulging of the tympanic membrane or a new onset of drainage from the ear. Diagnosis can also be made if there's a mild bulging and acute onset of pain and redness within the last 48 hours. A severe acute otitis media infection is considered to have occurred when there is a moderate to severe pain for at least 48 hours, or a high fever, which a high fever would be considered a fever of greater than 102.2 degrees Fahrenheit. The client may most commonly experience fever, pain, and trouble hearing. Other signs and symptoms include experiencing tinnitus, back pain, sinus drainage, and sore throat. And of course, younger children that can't tell you these things, they may just cry and pull at the ears. So first-line treatment is going to depend on the age of the client, the severity of the infection, and whether or not the client has had amoxicillin in the past 30 days. Antibiotics should be prescribed for severe acute otitis media and non-severe bilateral acute otitis media in children 6 months to 23 months for 10 days. In cases where there's unilateral non-severe acute otitis media, a decision between parents and providers should be made to determine if watchful waiting for 48 to 72 hours should be used or if an antibiotic should be started immediately. And this is important to consider because, again, like we talked about earlier, 80% of these infections will resolve on their own. When they are started in this instance, the antibiotic therapy doesn't last quite as long. It usually lasts about 5 to 7 days. Pain relief measures are required for the first 24 to 72 hours because it is a painful type of infection. Second line treatments. So if we use the watchful waiting approach and there's no improvement in 48 to 72 hours, they need to go ahead and be started on an antibiotic. And we'll talk about what types of antibiotics here just in a few minutes. Clients with failure to improve after initially being started on an antibiotic within 48 to 72 hours need to be reevaluated for a differential diagnosis or the possible presence of an antibiotic-resistant bacteria. And a differential diagnosis may just mean they have fluid buildup back there and not an infection, which would be a middle ear effusion. My son had that issue. He didn't have the pain, but he had the bulging of the tympanic membranes. So first line therapy, if they don't have a penicillin allergy, we're going to go right to amoxicillin, which is kind of that pink bubblegum flavored suspension. If your child's ever had an ear infection, you've probably given this to them before. Amoxicillin is a beta-lactam antibiotic, and beta-lactams work by inhibiting the biosynthesis of the bacterial cell wall. And again, it's the first antibiotic of choice if the client does not already have a high fever like we talked about. They've not had amoxicillin in the past 30 days and they're not allergic to amoxicillin. So this is for milder infections. So we're going to try this first. If it's a heavy duty infection, we're going to use an antibiotic that will cover, is a little more broad spectrum. So you can read about the pharmacokinetics. The brand name is Moxitag, which I've never heard that before, but that's the brand name, and you can kind of read about, the dosing on that. It's always best as providers to use as few doses as possible. We definitely want to educate parents that they need to give all the doses evenly spaced, so as few doses that we can get that into, the better compliance. Amoxicillin clavulanate also works by inhibiting the biosynthesis of the bacterial cell wall because it's got amoxicillin in it, but it also has the added benefit of clavulanic acid, which inhibits the beta-lactamase, which is produced by some bacteria, as a defense mechanism against beta-lactams such as amoxicillin. The patient should receive amoxicillin clavulanate if he or she has had amoxicillin in the past 30 days, concurrent conjunctivitis, high fever like we talked about, the initial antibiotic treatment has failed, or has an infection with bacteria that produces beta-lactamase. So this is our more heavy-duty antibiotic if it's a more severe infection. And you can read about the pharmacokinetics and the dosage. The brand name of this one is Augmentin, or, sometimes there's extended release that can be used, and that's Augmentin XR. So there's different therapy for those that have penicillin allergies. We can use cephalosporins for that. There's several listed here. Again, these right here are going to be your first line for infection, and so this is if they don't have a high fever and they don't have any other concurrent concerns that we have. So there's 3 different ones listed here. There's Ceftonir, Omnicef, Cefuroxime or Ceftin, and Cefpodoxime or Vantin. If the client has a high fever, like we talked about, greater than 102.2 degrees Fahrenheit, we're going to go to a more heavy-duty cephalosporin, which is ceftriaxone, which you guys probably know as Rocefin. And heavy-duty infection, we're going to give that IV or IM for 1 to 3 days. The other option is clindamycin, and this is the only non-beta-lactam and non-cephalosporin that we would use for this type of infection. It's a lincosamide, and it works by inhibiting bacterial protein synthesis. And again, you can kind of read about these pharmacokinetics and dosage on your own. If we do give the clindamycin, we are going to pair it with one of the third generation cephalosporins, such as this Rocefin here, one of the other first line cephalosporins that we talked about on the slide before. If there's no signs of improvement within 48 to 72 hours, IM, ceftriaxone, or Rocefin, 50 milligrams per day is given for 3 days. And if we've already done that, we're going to do a tympanocentesis because our antibiotics are not working. Pain relief measures are required for the first 24 to 72 hours. Acetaminophen or Tylenol reduces pain by possibly decreasing prostaglandin levels. And you can read about the pharmacokinetics and the dosage there. It does start to peak after an hour, and most of us know that about Tylenol because we've taken it before. Ibuprofen, also known as Motrin or Advil, reduces pain by inhibiting cyclooxygenase activity or COX activity, which helps prevent prostaglandin synthesis, thereby reducing pain and inflammation. So again, this one peaks in 1 to 2 hours. Important to note the dosing on these though. Tylenol, 15 milligrams per kilogram per dose every 4 to 6 hours, max of 5 doses in 24 hours. We want to make sure they're not overdosing the child on Tylenol because we don't want to cause Tylenol toxicity. Also with this ibuprofen, we need to be careful with the dosage. 5 to 10 milligrams per kilogram every 6 to 8 hours. So here's some drug therapy for prevention, and that's going to be your vaccinations. So pneumococcal conjugate vaccine is going to be the one that's going to be help be effective against that Streptococcus pneumoniae. It's got multiple strains of pneumococcal bacteria in the vaccination, and if it's given at 2, 4, 6, and somewhere between 12 and 15 months of age, it reduces the risk for acute otitis media caused by pneumococcal bacteria. Brand names for this is Prevnar 13, Synflorix. It can be given IM or sub-Q, interestingly enough, and you give a 0.5 ml regardless of age. And it'll produce antibodies within 2 to 3 weeks, and those will last for 3 to 5 years. Annual influenza vaccine injections for children 6 months and older reduces the risk for secondary infections. So again, it does not protect against the bacteria Haemophilus influenzae, but it helps reduce the fluid in the middle ear that can occur secondary to infections. These flu vaccines can be given annually to anyone over 6 months of age, and they generally produce antibodies within 10 to 14 days and will last 6 months to 1 year. Brand names are Fluzone or Flublok. If it's a young child, 6 to 35 months, they'll get 1/4 ml, 0.5 ml for ages 3 and up. So there's multiple interactions here that I'll kind of let you guys read through. Some of the biggies that I've noticed kind of going through here is many of these antibiotics will interact with anticoagulants and antiplatelet agents, making bleeding more likely. And the same thing here with the ibuprofen because it's a non-steroidal anti-inflammatory. So if for some reason we're already on any type of blood thinner or anything like that, we need to be very vigilant, and we may have to be a little more picky about our pain relief measures. Also, let's see, oral contraceptives with the amoxicillin. Again, we're really talking about children here, but if you had an adult taking that, you'd need to kind of warn them that it makes the oral contraceptives less effective. But just multiple interactions. The vaccinations seem to have fewer. There's no known interactions for the pneumococcal vaccine. The influenza vaccine is going to be less effective if the child's already on immunosuppressants or anti-neoplastics. They're not going to have as much of an immune response to the vaccination. And there's a few medications here that can cause decreased clearance of the vaccination. And then there's several different adverse reactions to these medications. The big ones with the antibiotics are going to be gastrointestinal, and then, people tend to have allergies to some of these medications. So, we're going to warn the parents that, the medications may make them a little nauseous. They could possibly have some diarrhea with some of these medications. Some of the antibiotics, it can be common to cause a C. diff infection after taking them. So important to educate them on things like probiotics after taking or while we're taking some of these antibiotics, and then just watching for hypersensitivity reactions. For acetaminophen, the main thing is that they're careful about the dosing because they can get Tylenol poisoning, and you can see some of the symptoms of that there. The ibuprofen, it can cause GI bleeding. Again, we need to be careful, and make sure we're watching for things like that whenever we're coupling it with the antibiotics that can make the child more prone to these types of problems. And can be hard on the kidneys, so need to watch and make sure the dosage is appropriate. Pneumococcal vaccine, not a whole lot here, some irritation at the injection site, and they can just feel kind of crummy for a little while after they get it. They can have a low-grade fever, not a very good appetite, maybe kind of drowsy and achy and irritable. The flu vaccine, some of the same types of symptoms as the pneumococcal. Important, though, to check for an allergy to eggs. Make sure that's not present if we're going to administer the influenza vaccine. Dietary changes. Here's a few things that studies have shown that kind of may help to prevent acute otitis media. Breastfeeding for the first 6 months. Children that do this, studies have shown, have lower rates of acute otitis media. If they're getting these types of infections over and over again, an elimination diet may be suggested for older children who might have allergies contributing to these recurrent infections. A lot of the time, some of the offending foods may be dairy products, wheat products, so that may be something to try. Vitamin D supplementation has been shown to decrease the risk for acute otitis media. And then probiotics, while they don't directly help decrease the risk for acute otitis media, they do help to prevent colds, so that may indirectly reduce the amount of middle ear infections that the child might get. Lifestyle factors, we're going to limit exposure to irritants like secondhand smoke. We're going to avoid using a pacifier, and we're going to try to get sick. Limit time in daycare around sick kids if possible. Keep children away from those who are sick. Xylitol gum for older kids, that's been shown to reduce the risk for acute otitis media if they chew it 4 to 5 times a day. Non-pharmacological treatment for pain, warm moist cloth over the affected ear may help reduce pain. We already talked about that the tympanocentesis may be required if the bacteria is resistant to antibiotic therapy, and a myringotomy may be required if the child has recurrent infections. So just to conclude this presentation, acute otitis media is the most common bacterial infection in young children. The watchful waiting approach works for the majority of children, but in other cases, antibiotics and other treatments may be necessary. Thorough education of parents regarding the prevention and completion of antibiotic therapy is important to prevent the recurrence of illness.